Today we have an expert psychologist and author, Dr. Tracy Stecker. She recently wrote the book, Choosing Help, Your First Steps Towards Better Mental Health. So welcome, Dr. Stecker. Thank you for being here.
Thank you for having me.
Just a quick reminder for everyone, please mute yourself during the conversation. If you have a question, feel free to put it in the chat. We'll be monitoring that throughout the hour. And also at the end, we'll have some time for questions. So, Dr. Stecker, again, thank you for being here. In your book, you report that about 1 out of 5 individuals experience a mental health or substance misuse disorder at some point in their lives, which seems kind of like a lot.
Mhm.
However, you also point out that the majority of people with these issues don't seek treatment.
Correct.
And I read recently a statistic that 20% of people that schedule the intake appointment never go back for a second appointment.
Mhm.
And I think only 40%, 20 to 40% accomplish their treatment goals.
Yeah.
So I think I'm very excited about this conversation from a personal standpoint, right? How do we get people that we love to seek help and choose help? And also from a clinical standpoint, a mental health and public health standpoint of how do we make it more accessible for people to choose help?
Yeah.
And once they have chosen help, once they're sitting in our office, what do we do from there? Because sometimes we do get that resistant client or that like plateau of, how are we making progress and how do we get somebody to be a little bit more motivated or show more, success or accomplishment in their treatment goals.
Right.
Um, so first off, why don't you tell us a little bit about your background, your inspiration for writing this book, and if there was, a specific experience or a pattern of behaviors that really made you want to write this book for everybody.
Yeah, so I'm Tracy Stecker. Thank you for having me. Love being here. It is absolutely true that the majority of individuals with mental health or substance use disorders never get treatment. And of the ones that do, they bounce out pretty quickly. So we definitely have a situation at hand here where there's room for improvement. I started my quest to help improve treatment seeking as a baby. I had a father who was a Vietnam vet, and he came home from war, very, very traumatized. And so, as a little kid, not knowing really much about anything, I knew that he was really struggling with his situation, with his triggers, with his trauma. And as even a child, I thought, why doesn't he get help?
Mhm.
That grew into a profession. I became a psychologist and I wanted to be a clinician and a researcher, and everything I've done in my career, and I am old now, um, has been focused on improving treatment seeking. So here's what we know about when somebody has mental health or substance use problems. About a third of people who are in pain come running right away. This is not okay. I'm depressed. I'm anxious. There was a trauma. Somebody needs to help me fix this. So about a third of people will scream at the door, let me in and help me. So this book is not for them. They're in the system. There's another third who will come in. They notice that they're uncomfortable. They notice that they're in pain. They will come in if it doesn't resolve itself. If some of their strategies that they're using to make it better aren't working, some of them will trickle in and some of them go to that third group. The third group, those are my people. Those are the people that are kicking and screaming and saying, absolutely not going to treatment. I'd rather die. I'd rather suffer for the rest of my life and let my family suffer than go and get help, than ask for help. This book is really oriented towards those individuals and their loved ones to help them really work through that decision of seeking help.
Hmm. I think also for clinicians, I know I hear it a lot. I'll have a client, but they talk about, a spouse that should seek treatment or needs help, or a family member who might be, I have a client now with a son who has some substance, misuse. And
Right,
it's, even as the clinician, sometimes it's like, oh, I don't know. I don't know how to, force them, to get help,
right.
especially if they're adults.
Right.
Now, the title of your book, I love because it is, it's not just getting help or therapy for everybody. It's
Mm-hmm.
choosing help. And I think you did that pretty intentionally and
Mm-hmm.
purposefully. So could you explain a little bit more about why the choosing part is so important and impactful?
Absolutely. So a lot of individuals have a idea about asking for help. I'm not sure where everybody learns it. I'm not sure where I learned it myself. Well, I probably did learn it from my father, um, but we do grow up, um, and we understand at some point in our life whether it's comfortable to ask for help or not, whether what kinds of help you can ask for or not, what kind of problems you might have where you could ask for help or not, what kind of people you might go to and which ones not. All of those ideas get formed somewhere, and we don't really give ourselves time to think about them.
Mhm.
They get pretty formed and formed solidly, and yet we don't really question it. So my whole approach has been to question it. Let's pull out some of those thoughts. Let's think about them. Let's think about whether they're true or not. And if there's any room to modify that thought that you have, let's modify it. Let's make it more true for you, or um, more open for you.
Mhm.
So for many people, asking for help is a no. It's an automatic thought. They learned that when they were two.
Mhm.
Nope, not asking for help. Maybe they don't trust anybody. Maybe that was something that was not welcome in their environment when they were young. But being able to talk about it, talk about their thoughts about getting help, what help means to them, what it would mean about them if they needed help. That's what the choice is. So let's talk about all of those aspects for them. What would it mean to them? And then make maybe it's the same decision, but maybe a different decision based on the discussion.
Mm. And have you seen any particular patterns of individuals that find it hard or more difficult to ask for help? Is there kind of like not a case example, but a model person or client that you can just tell, that they resist, choosing help?
Uh, uh, yes. So individuals where there will be consequences to their job tend to have a hard time asking for help.
Mhm.
Cops, people in the military,
Mhm.
physicians, some providers. If there might be potential consequences to their job, that thought comes up right away. Oh, I can't. This will potentially hurt my career.
Mhm.
So that is always in the back of my mind when I'm, you know, aware of somebody struggling and the potential for consequences to their job. Other than that, everybody is, maybe has one of the thoughts that get in the way with treatment seeking.
Mhm. Right. And I think, I've had clients too, and when I started out with my career, I worked primarily with children and teens.
Mm,
So it's interesting again, the choosing help because sometimes they didn't have the choice to come. A
right.
parent or a guardian would strongly encourage them. And I would always say, I'm not going to make somebody, go through the therapeutic process if they don't want to, if they're not ready, because then that's going
Hmm.
to just set them up for, not wanting to do it maybe in the future.
Hmm.
Um, but a lot of times too, clients would say like, "Oh, I'm just going to Kortney," and a client would say, "My family, they won't say therapy. It's I'm
Hmm.
talking to Kortney today,"
Hmm.
or "This is my special friend,"
Hmm.
or we don't talk about that. And but then now I've seen, and I don't know if you have either, like kind of a reverse of everybody's in therapy. Everybody has a therapist. It's kind of like the in thing to do. And now with like life coaches, and I'm
Hmm.
wondering, like you said, and in the book you talk a lot about active listening
Hmm.
and what it looks like for somebody. What does help look like? What are your, thoughts about that? How would you best present getting help to someone who is resistant? Like maybe it's not, you need psychotherapy, individual counseling once a week. What's that first step for us wanting to encourage someone to choose that help?
First step, first step is what are your thoughts about getting help? So
Mm.
really identify. There really are. It's interesting. I've done, as I said, I'm old and I've been doing this for a long time. I've looked at resistance to help seeking in a variety of different disorders, people with a variety of different presenting symptoms. There are pretty much 8 beliefs that people say are the reason they're not going into treatment. And they are stigma,
Mhm.
I'm not ready, I don't have time or money for that. They're going to make me get some type of treatment I don't want. Typically, they'll just try and shove a medicine down my throat and I don't want it. Or
Mhm.
they'll make me go to 8AA and I don't want it. Not AAA, AA. I can handle it on my own.
Mhm.
I don't need help. And there's one more that I'm just blanking right now. But people, regardless of the condition, tend to present one of those 8 thoughts. And they present them the second you ask, what are your thoughts about getting help? They will say pretty much one of those 8.
Mhm.
So that's step one. What are their thoughts about treatment? Find out what that is. And then step two is ask them more about that. Tell me more about that thought. Where'd you get that thought?
Mhm.
Um, when did you learn it? So, for example, that one about if I go to treatment, they'll just give me a medicine. Is that true? Is that 100% true? So, for example, if somebody has depression, they're depressed, maybe they've lost a parent and they're grieving, and if they feel like it's prolonged grief, and maybe they're thinking I might need help, but I can't get help because they'll just give me a medicine, and there's no medicine to take away grief. So their thought is, I'm not going to treatment because I'll just get a medicine. But if they go to a provider that can't prescribe a medication, they're not likely to get a medicine. And if you just kind of go further in that conversation, just have it another couple of minutes, they'll go, oh, yeah, I could talk to somebody.
Mhm.
But if you just ask them, why aren't you going to treatment, or what are your thoughts about treatment? They'll say, that's why.
Mhm.
So it just allows for the conversation. So if somebody's resistant, ask them their thoughts and then let them go a little further with it.
Mhm. It's funny, I laugh because I've had clients too that will come in and it's like, I'm not going on medication. I was like, well, good, because I can't prescribe medication for you. So we're okay.
Right, right.
But I think
And
you bring
many
up,
people won't even come in because that's
Mhm.
exactly what they think. Yeah.
Right. Um, Now, how much of that do you feel is kind of, misconceptions about therapy? And then once they, ask, they have a clearer picture, or with some of the reasons why they're not choosing help, more of like that, like defense mechanism or something more inside of them that's making them not want to take the next step.
My experience, I can't explain why it's true, but my experience is that people don't, people have a thought about treatment and they don't really explore it any further. It kind of stays right there.
Hmm.
So for somebody like me at a very early age, obviously, I became a psychologist and I devoted my career to helping people seek help. At a young age, I thought help is good.
Hmm.
Other people have a very different perception. And once you have that thought, for I'm not sure why, but that thought really sticks. You just don't explore it. Maybe we're not comfortable talking about seeking help with each other.
Hmm.
We just kind of let everybody have their thoughts. For example, if you knew a friend was struggling and you said, "Hey, what are your thoughts about getting help?" And they say, "I don't have time for that, and I don't have money, and I'm too busy." The conversation might stop there. But if you drew it out a little further, well, how much time would you need? What do you mean by time? And just like my book goes way into more detail about time and money, but if you just really extended the conversation a little further instead of it being a stop, um, there might be more progress.
Hmm. I was going to say too, in your book, you do a really good job with the resources and free resources
Hmm.
for people, because you're right. I think that's one of the things we hear mostly. I don't have time and I don't have
Hmm.
the money, even, for the co-pays. Um, and you're right. Usually that's where the conversation stops, because it's like, oh, yeah, it can be expensive. But I
Yeah,
was pleasantly surprised to read of all the different, free resources and,
right.
what even getting help could look like for somebody who can't afford a private practice once a week type of of setting.
Right. Absolutely.
Mm. Um, One question too is what actually helps people, or when you were talking about, they think they can get over it, get through it on their own.
Mm-hmm.
What is that shift though? Because you talk about sometimes people won't seek treatment until there's a crisis.
Mm-hmm.
And usually in the intake, we always ask, why now? Like what brought you
Mm-hmm.
here now? But
Mm-hmm.
what is it innately about people that either can recognize, okay, I'm in crisis and need help, or is it, do they have influence from other people that's getting there? And is it harder to help somebody, once they've decided to make an appointment, who is in crisis for getting help?
Yeah. I think it's a good question. I have a couple of different answers. So I'll check in with you after to make sure I answered your question. But for people who have the thought, I, whatever's happening in their life, and they think, I got this, I'll have to handle it on my own for whatever reason. I can handle this on my own. Whatever their strategy is to manage that situation either works or it doesn't.
Mhm.
When you work with a professional, you are going to have defined goals, defined strategies, a timeline. When you're doing it on your own, a check-in, like is your plan working or not? That's something that we provide as providers and as professionals. When you're doing it on your own, it's a lot easier to um, be vague on your strategies, vague on your goals. Um, Not necessarily be honest with yourself about your check-in. So if you just think about somebody, this is just a broad example, but somebody who wants to lose a little weight, their goal might be, I want to lose 10 pounds. Their strategy to lose 10 pounds might be specific and concrete, measurable, achievable, relevant. I'm going to lose 10 pounds by X, Y, and Z. Working out more, cutting my calories, whatever it happens to be. But then on their check-in, that's where things can get kind of fuzzy for them.
Mm.
They can justify, well, I had to go to that dinner and then, I was really stressed out at work. There can be a little bit of fuzziness around their strategy to meet their goals. When you're working with a professional, that all of that becomes concrete. You talk about that. You allow for some flexibility in the plan, but also you're sticking to the plan. You're really assessing what part of the plan is working and what part of the plan do we need to maybe tweak. When you're doing it on your own, it's really easy to get off track pretty quickly. So my guess is a lot of people come in for help in crisis. They've already known way back something was going on, but they could handle it on their own, or they weren't ready, and they employed some strategies, and then the wheels fell off the bus, and they're like, everything I've tried didn't work, so now they're coming in. So I think it's important if you have somebody who's coming in your door the first time in crisis, acknowledge all the work that they've already done, because
Mm.
they probably have tried several things to stay on track. And I think it's really important to acknowledge all that work. They probably were trying
Mm.
to handle it on their own. And and you can find out from them what parts worked. There were probably parts of their plan that worked really well,
Mm.
and probably parts of their plan that didn't.
Mm.
So identify them. Let's identify them. Let's tweak the goal. Let's tweak the strategy. Let's really check in with what parts are working and what parts aren't. For the parts that aren't, we're going to get those so that they are working.
Mm. Good. We have a question. I'm not sure. All right, so it says how to move someone from antidepressant medication alone to talking with someone, especially having lack of success with medicine.
What are their thoughts about getting talking therapy?
So again, asking like kind of that information seeking, figuring
Hmm.
out.
Yeah.
Yeah, and I think you bring up a good point because a lot of times people want to feel like we want to give them autonomy, right? And
Hmm.
realize that, like, again, with the title of the book, Choosing Help, that they're
Hmm.
not forced into this.
Hmm.
And when you take the time to really listen to somebody, try to figure out their point of view, even if you don't agree with it,
Hmm.
that's going to give you a better understanding of, why this person might be hesitant. And I would
Yeah.
assume it's going to make the other person feel more validated, more heard, and more like, okay, it's not someone just, I mean, nobody likes to be told what to do. But
Right.
when you have that option and how you say things to people. There's another comment about strength-based conversations. Instead of saying, you should stop drinking.
Hmm.
If you ask the question, have you ever thought about not drinking as much?
Hmm. Yeah.
That's going to have a completely different response from that person.
It's also true. It's the conversation goes so differently when it's somebody you're working with professionally versus a loved one.
Mm-hmm.
The way that sentence comes out can be really different. However, it's really important to remember skills, empathy, genuineness, respect, and active listening when you're talking to a family member, maybe even more so. We kind of do it naturally as professionals, but when it's our loved ones, even us, we're like, you need to stop.
Mm-hmm.
There's nothing about that sentence that's very helpful.
Right, exactly. Um, could you speak a little bit more about active listening?
Yeah.
Because I think people assume that, we're really good active listeners because it's, oh, I am listening to that person.
Hmm.
But I was reading some book and it said about 17% of people really are active listeners. And when it gave more examples, it was like when you're having a conversation with somebody,
Hmm.
you are just listening to them. You're not thinking about, oh, how do I respond? What question should I ask next? Which I know I do sometimes, especially in even with these or in a professional setting. It's like, okay, well, what am I going to talk about next? So you're not really present in the moment.
Hmm.
So, yeah, if you could explain a little bit more about really what active listening is and if there's any skills or how we can become better listeners, especially
Yeah.
to our loved ones.
I always picture the monkeys. Um, the, the monkeys with the,
Hmm.
but that's exactly, it's three steps. Active listening is three steps. You have to hear the words with your ears. You have to let the words actually hit your ears. That's step one, and hear the words. Then step two is you let your brain actually process and just hear and understand what they were saying, what their words were, and what does that mean? What did you hear? And then you use your mouth to confirm that that's what you heard or not. The
Hmm.
next step with your response comes later. But active listening is hearing, processing, and then confirming what you heard, which is really, really important in a crisis situation when somebody is considering whether or not to seek help. Just understanding their situation, listening to what they're saying, really processing what they're presenting with, and then confirming that you heard it back. As providers, I cannot tell you how many times I have verbatim said back what the person said to me, and they have gone, no, that's not it.
Mm-hmm.
Okay, well, what is it? Tell me more about what you really mean. Or I verbatim said what they said back. I've said back to them verbatim, and they have said back, yes, you understand. And it's
Hmm.
like such a relief when somebody is listening to you. That last step, confirming what you heard, is a very important part of active listening that hardly any of us do. But in these situations, it's really important. And we all have had examples when we're maybe fired up or want to share something and somebody really hears us, they take the step that step to confirm what they heard. It's so validating. Just to feel heard. Uh, Even that phrase is thrown around our culture all the time. Just to be heard is so important. And so to be heard, you have to take that last step and use your mouth to confirm that you heard them correctly. If you didn't hear them correctly and you got something tweaked, it gives them an opportunity to fix it. No, oh yeah, maybe I said that, or no, you didn't understand right. It's more like this. So you're still taking time to understand and listen to their perspective.
Hmm. Right.
The monkeys.
Yeah.
I,
It's a good visual. Um, okay, so once somebody has said, okay, I think I'm going to go get help,
hmm
the loved one, and like I said, even the clinician is probably like, okay, we're here and everything
hmm
should be, easy now and we know what we're going to do. So
hmm
how can, a family member support somebody who's that initial step of getting help? How can, the clinician, and then later on we can talk about on a broader sense, how can, communities and different agencies make it easier for people to get help and then also stay in
Yeah.
treatment?
Yeah, there's a bunch of different answers that I have there. There was a bunch of different questions.
Yes, there was.
I'm gonna do my best.
You can pick
But
and choose.
I think the most important part is active listening. Um, Making sure that you're on track with them, their goals, their strategies to achieve their goals. And then, you know, in the book, I have a chapter on stigma.
Hmm.
Stigma is actually a really important thing in terms of the community, in terms of that individual. There's two aspects of stigma that interfere with treatment seeking. One is just judgment by the community. Being perceived as somebody with a mental health condition or a substance use condition, and they don't want to be judged. So there's this whole concept of confidentiality. We as professionals, I think, are pretty good at confidentiality. The perception by the community, however, is that we're not.
Mm.
Um, there is a perception that there's a list. And if you go in for treatment, you're going to get on that list. And they don't want to be on that list. There's no list. If you have a very serious and severe mental health condition in certain states, you might get on a list in certain states. That means you might not be able to purchase a gun. In other states, if you're going in for depression or a substance use issue or trauma or anxiety, there's no list. There's absolutely no list. The
Mhm.
community doesn't know that. The community thinks there's a list, and the second you go in to talk about your anxiety, you're going to get on this list and everybody's going to know. So one of the things we can do as a community is just verify to people that if you seek help, it will remain confidential. If you want someone to know, tell them. If
Mhm.
you don't want somebody to know, don't tell them. If you live in a small rural community, I never say that word right.
You did great.
If you live in a small community and there's only one mental health counseling center, and you don't want to go there, that's also okay. There are lots of online resources available. So no matter what, confidentiality, I think, is key. We need to do a better job of letting the community know that um, people won't know unless you tell them. And then the second thing is just reiterating, because it's not just community stigma, it's self-stigma. Somebody doesn't want to say, I have a mental illness.
Mhm.
Most of us don't want to say, I'm mentally ill. I have a substance use disorder. I'm an addict. There's this perception that even just that individual, they might be struggling, but they don't want to admit that. So it's self-stigma. And I think we can do a better job of talking about underdogs and overcoming obstacles. Movies are made from this concept all the time. TV shows, if you look at movies and TV shows, a lot of them are about overcoming obstacles. Some of our greatest athletes that our culture, really respects are people who overcame an obstacle and then became a champion in their field. Overcoming obstacles, focusing on the underdog, these are really important things that we just don't think about in terms of mental health or addiction. But why not? Let's focus on that.
Mhm. Okay, we have a question. I don't know if you can see it too, Tracy, but
I can't see the chat at all.
okay. I'm at LPC in Missouri, currently working as a mental health consultant in St. Louis, 30 years experience in university and K through 12 setting, seeking advice with helping K through 12 faculty with addressing depressed youth. So,
Yeah.
and Donald, you can add more if you'd like. Is it more about how to get the faculty, like the warning signs, or what to do if you have a depressed student or resources for schools? And maybe Tracy, you could talk to about all of that. But
Or the parents, getting
I mean,
parents.
yeah, there's a whole lot that goes into working in a school system. That is for sure.
Mhm. Yeah, is there, I'm sorry, I'm just trying to understand a specific question. So just focusing on youth, it does get complicated because you've got a school system, a parent, and and the child. So you're not just trying to get an individual to come and talk about what's going on for them, but you've got the trifecta. You've got three different systems, and some of them might be contradicting each other about
Mhm.
whether or not to talk. So it is, I appreciate the complexity in that situation. Oh,
Donald might unmute and ask, but we can when he does, we can move back to that.
okay.
Um, what else could, and this might be a bigger conversation too, but I know sometimes, clients will come and say, I don't want a label. And like you said, it's a stigma and a label, and they don't necessarily feel comfortable with the diagnosis. Some come and they want that because it's kind of giving them, oh, now, a better understanding of things. But a lot say, I don't want to be diagnosed with this. And I guess, unfortunately, or it is what it is, if you go through insurance companies to bill insurance, we need a diagnosis. And usually it's on the intake session.
Mm-hmm.
And again, like you said, and I try to explain, there is no lit, like this doesn't, like it's
No,
not
but
a label on you. It's nobody else will know. But
you
I
don't
think
get a
that's
tattoo on your
right.
forehead. Treatment
But I
seeker.
think that's also, an issue, like a larger issue too. And I think perhaps that's why more people are seeking like life coaches,
Hmm.
which, have benefits, pros and cons to that, and especially what you're looking for. Um, yeah, but do you have any insight or how to help somebody get through the label part of choosing help?
Yeah, I mean, one of the things that comes to mind that has worked with other people who have brought up this thought is that let's say you're struggling with depression. I'm just gonna grab one. You are having an episode of depression and you decide you want to seek help, but you don't want to be diagnosed with depression. Just because you seek help, you're having a depressive episode, for example, or you seek help for depression, does not mean you are depressed for the rest of your life. It might mean you had an episode of depression or there was something going on. And just understanding that there are, especially veterans, I work a lot with veterans,
Mm.
they believe that once they hit treatment, they're in treatment for the rest of their lives. They don't know that treatment is often very time limited. 8 sessions, you're going to get 8 sessions.
Mm.
That's how much I can help you. And what you take from that, you take. I hope you weren't, I hope that wasn't as noisy as it was on my
Oh,
end.
we
Sorry.
couldn't hear anything.
Oh,
No.
good. Okay. I have a dog right at the foot of my um, office here, and he was wiggling around and distracted me. But just because somebody has a depression or a diagnosis or a set of symptoms and they get help does not mean they're mentally ill for the rest of their lives. Veterans think that if they go to VA, they're going to be in VA as a mentally ill patient for the rest of their lives.
Mm.
Please no, that is not the case. You might come in for 8 sessions, maybe 12 sessions at most, but that's what we're providing. We're providing a protocol treatment, and you're going to go and use that treatment and move on with the rest of your life. So maybe just knowing that, sure, maybe you got help to deal with strategies to how to alleviate your depression, but you can use them in your life for the rest of your life. You don't have to carry the label.
Mm. Good. I was laughing because we have another comment, but can we see the dog? Because the dog equals treatment. Well, funny too, because there are a lot of therapy pets now, and even
Mhm.
schools have, social emotional dogs and cats, and
Mhm.
so there is some hope of getting rid of some of that stigma
Yeah,
with mental health, but I think we have a long way to go.
yeah, yeah,
Um, Now, in the book too, you also talked about, once the active listening is done, not that it's ever really done,
yeah.
we can kind of challenge people's way of thinking. And as clinicians, we know, it's through, cognitive behavioral therapy and the cognitive distortions. How could you easily describe that to somebody who is trying to help a loved one, or if we have a client that's trying to help her son? How could
Okay.
you explain that to someone who's not, a behavioral health professional?
The CBT process,
Hmm.
essentially. Oh,
Yeah.
one of my very favorite things to talk about.
Hmm.
So CBT is a way of helping somebody identify a thought that they're having, whatever it happens to be. Um, take that thought and and look at it more fully. Is their thought true or not? You would be surprised how many thoughts we all have during the day that are not even true. We think them constantly. Some of them are totally true. Like, for example, if I had the thought, I like having my dog right here, 100% true. And then I have that other little thought, but he is kind of noisy. He is making, he is disrupting me. So the thought is, I like having my dog here, but I would prefer it if he wasn't making noise. So you take a thought, whatever that thought is, and then you really just look at it more fully. Is it true? What parts are true? What parts are not true? You do it without judgment, though. There's no judgment on our thoughts. Our thoughts are just thoughts. They're not necessarily true. They're not necessarily false, but they're just our thoughts. They're fleeting, they're thoughts. Some of them we've believed for our entire life, but it's okay to look at them. It's okay to explore whether or not they're true for us, whether or not they're working for us. If they're not working for us, well, let's think about it more fully. So looking at our thoughts is a way of identifying a thought that you're having, maybe one that's getting in the way, exploring whether it's true or not, exploring where you maybe had that thought and why you had that thought, and exploring how to change the thought. Changing the thought is the most fun thing because it's easier than you think. All you have to do is figure out, well, what is true? What are the other thoughts that come along with it? Or you have that thought, but would you apply that thought to somebody else?
Hmm.
um, Even just exploring it more fully. So that's basic CBT. Just looking at your thoughts and then deciding whether or not they're true, are they working for you, and then how to change them if they're not true. Let's make them more true.
Hmm. And I know I play a fun game, fact or fiction, with my clients, and they love it and they hate it because it's like,
Yes.
true? Is it not true? Like, get the facts and then react, and it's
Mhm.
like a thoughtful process. And I think
Yeah.
I think people do like I teach the cognitive triangle too, and some people, aren't familiar with it. But then when I hear like a parent, talk with their child, I'm like,
Mhm.
you're doing it. You just didn't know that this is what it is. But I think we're better equipped sometimes to have these deep conversations with people than we give ourselves credit for.
Yeah, I have an example in the book that I used. I don't know what is compelled me to talk about it right now, but I'm going to. Uh, but the example of CBT that I used in my book is an actual example of me. I brought my 8-year-old son to tackle football practice. It was his first year he was allowed to play tackle football. He's my youngest child and my baby and a diabetic. He wanted to play football. He had been playing flag football for a couple of years and he wanted to play tackle football. He's a diabetic, so I'm at all of his practices by that point at 8 years old. And it's tackle football, and I'm just having all these thoughts. So I drive him to the field and it starts pouring. So now I've got three thoughts in my head. He's only 8 years old. This is tackle football. He's a diabetic child and it's pouring rain. Of course, they're going to cancel practice. They didn't. They kept practicing. I was in my car watching the practice like almost like a lunatic, trying to see on the windshield like which one is him? I couldn't see anything. It was all blurry. I had my windshield wipers. Is he okay? He's not gonna like this. This is terrible. And I was just having all these anxious thoughts about how miserable my child was out there in this pouring rain playing tackle football at practice. The whole hour goes by. He he gets in the car. I'm a nervous wreck at this point, but I want to hear what he's going to say. He gets in the car He gets and he sits down, he's sopping wet, and he goes, "That was the funnest day of my life." And so I had to like really switch my thoughts.
Hmm.
My thoughts were not accurate. I gave myself a heart attack the entire hour. I
Hmm.
didn't need to. He was having a blast. And the next practice, when we went to the next practice later that week, he was like this. And I said, "What are you doing?" And he said, "Praying for rain." So I knew then my thought changed. Rain is fun for these little kids,
Hmm.
right? So that's just a silly example, but how our thoughts can be totally wrong. And if our thoughts are wrong, go ahead and be open to changing them.
Hmm. Good example.
That's a
Um,
silly one.
what are some cultural barriers and maybe preconceptions about getting help, and have you seen in different, populations of people, and how can we be like what kind of respectful of different, cultural ideas about getting help?
Yeah. So, cops, veterans, firefighters, definitely a group of individuals who believe strongly that everybody else should get help, and it is absolutely okay to get help, but is not okay for them. So
Hmm.
that is a group of individuals who strongly hold that belief. Um, Different minority groups believe that it's a white person thing. Therapy is something that is more for privileged people. It's a white person thing. It's not for them. And so respecting that, so understanding that from their perspective, what is help to them? What would be helpful? What is help? And just being able to open that up to again, not shoving your own thoughts down their throat, but understanding what is help to them, then what are their options? What are their beliefs about getting help?
Hmm.
Um, Trying to think of different groups.
Well, and like you said before, what we think might help us
Hmm.
may not help, our loved one or our
Hmm.
client. So, right, it's just getting that understanding. We do have Donald. If he wants to unmute and ask more of the question, feel free to do so now.
I'm wondering if the microphone's working.
It is.
We
We
can
can
hear
hear you.
you.
Okay. I couldn't get my laptop working, so no visual either.
That's okay.
Um, I'm really, first of all, thanks for doing this. I mean, this is like, it's so fundamental that I think a lot of health professionals kind of miss the point, you
Yeah.
know? It really is.
Mhm.
We always have choice. A lot of us don't know it, as you probably talk about in your book, Tracy, you
Yeah.
know? And
Yeah.
it's like, and it's same with the teachers. When I work with faculty, a lot of times they feel like imprisoned in this no choice story, you know? And it's like, so I'm trying to find ways to let them know that despite all the craziness of school environments and the overwhelming thoughts of what mental health brings into our lives or mental illness, it's like, how do I help them see that, there's more to choice than we realize?
Hmm.
I,
Yeah.
this is right on the money. I mean, our whole life is built around choices.
Agreed.
Mhm.
So,
Agreed.
and then it gets into the other thing that, like Bernie Siegel wrote this book, you know, how to live between office visits. That a lot of times therapy is just a small part of the bigger picture. It's like giving you assignments and all that so that you can, have a productive life between that and the next office visit. And, how does choice work in that? How do I help, faculty, like they'll see their kids in class and it's almost like a miniature in between office visit experience.
Yeah.
Does that make sense?
Absolutely. Yeah. Uh,
And it's like, I know a lot of teachers, they see something going on and they try to refer to the counselors, what a lot of times view themselves as glorified secretaries because their caseloads are so darn high.
yeah.
So, I mean, a lot of schools, I worked under grant money as a mental health counselor, crisis counselor, and, the teachers just were thrilled that I was there. When the grant ran out, it became a problem,
Yeah.
because a lot of counselors are doing training and all the other things than what kids really need.
Mhm.
So in the end, it's like, when I worked in the school, I was always keeping in mind I was going to be leaving, and what do I bring to the school when I'm gone? Like I started a group program in the guidance sections of the high school, and I trained all these counselors and guidance on how to do groups. But a lot of that just disappeared, because I wasn't there.
Mm.
So, I mean, and yet these kids, they still need this stuff, and
Yeah.
and as you probably know, there's a lot of like hunger for mental health folks, in schools especially, because
Hmm.
the suicide rates are up and the lonely. I mean, it's in the news all the time.
Mhm.
So I don't know what to say. It's like, I know I have a choice in the story too, and I just want to use my time wisely to kind of, figure this out.
Yeah, I would recommend that, I do hear the school systems, I think um you're right. I have kids in the school system, and there's just it is really complicated and complex right now with our children and anxiety and the suicide rates and the loneliness epidemic. Um, and I just encourage everybody to remember that the school system doesn't have to solve all of this on their own. The pressure isn't all on that one school for those children. There are resources all over the place, all over that community even. So maybe just better connections with resources, or even, psychologytoday.com has resources. If you just look up the zip code, it'll have all the resources in the area, and people can just getting that information maybe out to parents so that parents have a choice of it, whether or not they want to get their child access to services, what kind of services, and then what's available in the community. I feel like that could really help maybe eliminate some of the pressure on the school system to do that be all end all at school, and while also having counselors available at school too. I think that that's also important, but it's not the sole job of the school. That does feel like a lot of pressure.
It's interesting. Next month, we do it every year, but a local high school has a mental health fair. And it's just tables, you set up, your business cards, any kind of information. And last year when I went, I was talking with another, clinician, and there's not a lot of interaction necessarily with the student, like when they come to your booth,
Hmm.
but they take things. And it's like, you know what? As long as they have some information that they know they can, reach to later or reach out, I think, we've kind of done our job there. And I think it's just there should be more opportunities for that. So people and, students and children and parents know what resources are out there.
Yeah, yeah.
Mm.
Just letting them know. I
Yeah.
know we are not good at communicating resources,
Yeah.
but there's a ton.
Well, we are coming up on an hour. So, Tracy, again, thank you so much for being here. If there's any takeaway that you would like to leave our listeners with, please do so. And if you have any, what they can take away from the book, the biggest takeaway, or what you hope, if they don't get anything else out of this conversation.
I guess the biggest takeaway is that the majority of people who need help aren't seeking help. And it is as simple as a good, healthy conversation to get them to change their mind. Um, Not throwing an agenda at them, but just asking them, what are your thoughts about getting help? Digging a little deeper on that and allowing them to really explore them more fully. Some beliefs about seeking help, all beliefs about seeking help are modifiable. All of them.
Hmm.
Tons of success changing those thoughts, even among my precious little resistors. Some of the thoughts are even very easy to change, and some of them are a little more challenging, but they're all modifiable, and you can get people to accept help willingly, openly. That's my take home.
Good. Thank you so much for your insight. It was a great conversation. And I hope everybody will join us next month for our other clinical conversation. Thanks,
Thank
everyone.
you. Thank you.